Okay, so any questions from Tuesday or anything we covered there? They're anesthetics, general anesthetics. We're going to talk about local anesthetics. So these are only state-based ones, right? They're not more national. Just kidding. Okay.
MAC, it's like talking about the potency of the anesthetic. Does
Yeah.
it say anything about how good it is or efficient
or? Okay, so the mean alveolar concentration. So talking about the potency, right? So saying how much of the gas it takes in order to cause 50% of your patients to enter that kind of state of anesthesia, right? So absolutely, so that has something certainly to do with how potent it is. And if you looked at like nitrous oxide, how that MAC was like above 100 or whatever it happened to be versus, some of the other ones which were like, point something or 1 point something. Basically just means you need a lot less gas in order to get that state of anesthesia. For nitrous oxide to get that deep state where I could cut open your belly, you would need to have so much that you probably wouldn't have enough oxygen to survive at that point. So it certainly goes back to the potency. And again, you're titrating all these gases to your response to where you don't have really that full medullary depression, but you're kind of in one of those kind of deeper stages of stage 3 of anesthesia. So it just matters how much gas you have to use. Any other questions? Yes, ma'am.
So to get to the medullary state, are they monitoring like the ABGs or like?
A lot of times they're monitoring. An anesthesiologist or like a CRNA might have better answer to that, but from my understanding, at least what I've seen like in surgeries and things like that, is a lot of it's based on their vital signs. So they'll be looking at things like obviously the heart rate, looking at the pulse ox, looking at their blood pressure, because that's going to take a hit with a lot of these different drugs, right? You see hypotension that comes about from that. But they're also going to be looking at things like their end-tidal CO2, which is again is basically a marker of how well they're exchanging gas and outputting that CO2 that their body's generating. So that's one thing that they'll be looking at. They're not really doing like serial ABGs like in the middle of surgery, right? Certainly they have the ability to do that. Like, have you guys ever heard of iStats? It's a very common one that they'll use. Basically, it's like a point of care kind of test where they can look at an ABG pretty quickly. So they probably have that available, so they can do things like monitor glucose, and they can also monitor some electrolytes and things like that. So that is available, but they're not necessarily doing that serially throughout the procedure. But they can see, like, is the patient breathing on their own at all? They can monitor for things like that based on the ventilator settings and all those sort of things. So they can kind of see what's going on from that standpoint. Yeah. Any other questions? All right, so we're going to continue on talking about local anesthetics. So nociception. What is nociception? Pain. Yeah, it's just pain, right? So just a fancy word for pain. But basically, a lot of this is mediated at the nerve endings, right? So if I cut your finger, like you're having nerve signals that are happening there at the finger that's transmitting up through the CNS, relating back to your brain, and you say, ow, right? So we can blunt that response. We can do things like activate your opioid receptors, which are going to be working a lot in the spinal column, also working up in the brain centrally. We can have analgesics like acetaminophen or NSAIDs blocks on the inflammatory properties that's seen with that. But we can also have local anesthetics that work specifically and very locally in order to deaden that response to pain. And so we're going to look at some ways we can do that with some of our drugs here. But essentially what we want to do is to effectively and also reversibly be able to block our impulse conduction. We want this to be a permanent feature. And we're going to be blocking pain sensation from specific areas, usually those that are going to be painful in the first place. So for instance, if I have a laceration, say again to the finger, I can do things like a digital block, where basically I just cut off all nerve transmission from that finger. The patient does not feel pain, and I can do my suturing, or I can do whatever I need to do. You'll find nerve blocks will occur, especially after painful procedures like joint replacements and things like that. And what's kind of the benefit of using additional some of these local anesthetics in conjunction with things like opioids? Yeah. Absolutely. So you can reduce a lot of the doses of opioids that you're going to need, because again, if they don't feel the pain, they're not going to necessarily need to have drugs for that pain. And so that reduces things like constipation and other issues, especially tolerance developing to some of the opioids. So you're going to find that a lot of these are opioid sparing, meaning they're going to be lowering your total dose that you need in order to help control pain for those patients. Did anyone know that the first local anesthetic was actually cocaine?
Yes.
Okay, good. Good job. You get extra imaginary points for you. Yes, but it's been around for quite a while. Do you guys know where cocaine comes from?
Coca leaf.
From the coca leaf, right? And that comes usually from? Colombia, South America, right? So again, this is you know, one of those things where they found, you know, the coca leaf's been used for you know, hundreds of years by some of the indigenous people there, and we had, you know, explorers go down and we found that, okay, wow, this stuff's actually really good, gives you a nice little energy boost. When we were able to isolate it out, that's when we were able to find that it had some very good properties that make it useful for things like ENT procedures and as a topical anesthetic. Do you guys know of any of the other benefits of using cocaine for that type of setting? So you feel amazing. Okay. Don't do drugs. Vasoconstricts, absolutely. So acting as a sympathomimetic, right, increasing release of catecholamines, it causes vasoconstriction, which does what to your surgical site? Makes it less bloody, right? So, and also you're going to find that using things like vasoconstrictors, you guys know another common one you'll see used with local anesthetics? Epinephrine's a big one, yeah. So oftentimes you'll see epinephrine being used, and we'll talk about why that combination works, but a lot of it has to do with how much anesthetic you can use. It keeps your field looking better because it's not quite as bloody. It makes it easier to do whatever procedure you're doing. So there's lots of reasons for that. That's why cocaine's kind of nice, because it kind of performs all of those different features in one go. And so ENT procedures is probably the one place you're still going to see it used, sometimes some ophthalmology procedures. We used to carry some at Nemours because our ENT doc said that we're going to use it, and then they never used it, so we ended up expiring it and having to get rid of it. So we used to carry cocaine for our children, but not anymore. So, and you're going to see that a lot of the toxicity that comes about from these drugs extend from their therapeutic effects or their mechanism of action. So we'll look at some of those kind of systemic problems, and sometimes we're actually utilizing these effects for our benefits, and so we'll look at why that is in just a little bit. So how these are working, their mechanism is that they're going to be reversibly blocking impulse conduction, basically by inhibiting the action potential from traveling up the nerve. The signal never gets to your brain saying, hey, there's pain going on here. And a lot of this is being done by blocking the sodium channels. Okay, so all of these local anesthetics work as sodium channel blockers. Do you guys know where else we have a lot of sodium channels? It's really important to have action potentials being nice regulated, and yeah, the heart. So we're going to see that the toxicity, one of the big ones we worry about is going to be heart toxicity. So we'll look at how we can treat that a little bit later as well. But basically, by blocking sodium channels, you prevent those action potentials from traveling up the axon and preventing that signal from ever reaching the CNS. So as I mentioned, cocaine is going to be the kind of prototypical anesthetic. Do you guys, if you ever watch TV again, what's one way they test for the purity of cocaine? They taste it. Where do they rub it, though? Yeah, they rub it on their gums. Do you guys know why? Should go numb, right? So that's one way they can test to see if it actually is cocaine or something else, because like something like amphetamines or talc powder or whatever. I shouldn't be training you guys on how to be amateur drug dealers, but got to go to farm school for that to be professional. But there's actually some problems with that. We actually ran into issues where you know, some of these people are less than moral individuals. They would actually try to masquerade their cocaine by putting other anesthetic products into it. And so they put things like benzocaine into it, so that way when you rubbed it on the gums, you still got the numbing effect. You thought, hey, this must be cocaine, and you go and use it, and then you get some other problems that we'll talk about a little bit later. So yeah, so there could be, you know, always worry about adulterants anytime you're dealing with illicit substances. But some other ones you'll run into include things like prilocaine, mepivacaine. Some of the ones we use very frequently in surgery, especially for big nerve blocks and things like that, are going to include ropivacaine, bupivacaine. So those are big ones there. I'll show you the brand names a little bit later. Ropivacaine you'll see a lot used in conjunction with things like fentanyl for like epidurals. So you can see that used pretty frequently. And then obviously lidocaine being one of the most commonly used. You guys have probably all heard of lidocaine before. So very, very common one, especially used for not necessarily used for like large blocks or anything like that, but for, you know, kind of local anesthetic purposes, it gets used very frequently. So the kinetics of the drugs are going to vary pretty widely amongst one another. So it's important to look at the half-lives comparing these, and note that the apparent half-life, the actual duration of action can change and be different than what the actual just the hours based half-life is for these. So if you look at things like bupivacaine, you know, it has a 3.5-hour half-life, but once it gets into those channels, once it's blocking those channels, it has a tendency to stick around for a lot longer. So for instance, we used to use lidocaine for our digital blocks for doing like lacerations, but you found that within, you know, say 6-12 hours, the lidocaine had worn off and the patient was still feeling pain at the site, right? So you'd have to use analgesics and things like that to overcome it. You can give bupivacaine the same amount into that block and basically the patient's numb for like 2 or 3 days, right? So again, the duration of action can be different than what you would actually see with just the hours half-life mentioned here. But bupivacaine, ropivacaine, those are nice because they stick around for longer, have a longer duration of action, and thus you can have better some of the analgesic properties to them for longer. So looking at the absorption of drug, this can be important because this is going to be kind of linking back to toxicity that can occur. So the more systemic absorption you have of these drugs, the more likely you are to see toxicity associated with them, right? Because we want these to be local anesthetics. We want them working at the local site and not really traveling elsewhere. So that can be dependent on several features. So things like the dose that you're giving. Bigger doses, more likely to see more systemic absorption. The site of injection. So obviously if you're injecting it into a vein, pretty good bioavailability versus if I'm just doing it, say, subcutaneously, right? So that can be affecting the absorption. Things like drug tissue binding, so how well the tissues are actually binding up the drug and preventing them from circulating around. And then looking at things like the physiochemical properties of the drug, how lipophilic it is, how hydrophilic it is, going to have an effect on that. We'll also look at things like local blood flow. So the more local blood flow you have going to the site wherever you're injecting, the more likely you are to see absorption there. And that's where the vasoconstrictors come into play, things like epinephrine, because that will actually help to clamp down on that blood supply and allow for less systemic absorption of these anesthetics. That's again another good reason why we like to use epinephrine in conjunction with things like bupivacaine and lidocaine, because that prevents systemic absorption. So again, these are working to block those voltage-gated sodium channels. Again, they're going to be binding. Again, these are going to be affecting nerves that are more active. So again, if you're having a painful finger or whatever happens to be, those nerves are going to be firing more frequently because again, they're actively transmitting those pain signals. Those are going to be the ones that get more easily affected by these local anesthetics. So again, that's a nice thing, is that they're going to go right to their site of action. Other things you can see is that you can actually have electrolyte shifts be kind of antagonizing the effects of the anesthetic. So for instance, you can have elevated extracellular calcium levels. You know, so if you have high hypercalcemia, that could be a thing that can actually antagonize the effects. And also extracellular potassium concentrations actually can enhance these effects. All that has to go with how these electrolytes are being kind of shifted around based on the fact that you're blocking these sodium channels and preventing those action potentials from occurring. All right. So again, when you're applying these increased local anesthetic concentrations to the nerve fiber, basically you're going to see an enhanced threshold for excitation. So it's going to require a larger signal in order for the action potential to occur. You're going to actually be slowing that impulse conduction down, so it takes longer for those nerve signals to travel. It decreases the rate and the rise of the action potential, decreases the actual amplitude, so you get less of a big signal there. So even though you may not have full anesthesia there, you may still have some impact of it, may not be as big of a, you may not notice the kind of full effects of that. And then basically just we're shutting down those action potentials, so hopefully you don't feel any sort of sensation whatsoever. So using vasoconstrictors here as well, we kind of alluded to this, but basically by decreasing the systemic, or by decreasing the amount of blood flow happening there by about 30% on average, you reduce systemic absorption. This allows for higher tissue concentrations of the anesthetic, so it allows for better anesthesia developing there, lower systemic side effects, so you can give bigger doses than the anesthetic. So a good example of this is lidocaine. Good numbers to remember if you're ever in a case where you're doing like a lot of suturing and things like that. If you're using lidocaine by itself, say like 1% lidocaine, you want to use 5 milligrams per kilogram as like a max dose you want to inject, right? Above that, you start to see toxicity. When you include epinephrine with that combination, now you can bump it up to like 7 mg per kilo. Okay, so now you can give even more drug to the site in order to make sure that you have, because again, if you come in with a really large laceration, and again, I'm just talking from the ER perspective, this is where I most commonly see these being used. You can use up a lot of lidocaine pretty quickly in order to numb up the area to do your procedure. So it's important to make sure that you know those max doses, so that way you make sure you can give the patient what you need to and not give too much more than that. And then also using the epinephrine is going to help to lead to less bleeding, so your site's a little bit cleaner and you can do your thing. Okay, so looking at the actual structures of the anesthetic, so the ones that are smaller, that are more highly lipophilic, they tend to have an easier time interacting with those sodium channels just because they can go through and interact with those cells a little bit more easily. And so you're going to find that the potency of the anesthetics actually is going to be correlating positively with their lipophilicity. So the higher the lipophilicity, the more potent the drugs are going to be, and the less drug you actually have to use in order to block these conductions. You're going to find that drugs like lidocaine, procaine, bupivacaine, those are really going to be a little bit more water soluble. So that's why they're going to have higher doses that you need in order to interact with those receptors the same way that something like bupivacaine or ropivacaine can. So again, these are more lipophilic drugs that stick around for longer and they're going to be more potent. So the usual routes of administration, so we can use these topically. So there's a couple different forms that we can use. Mostly lidocaine gets used topically. What do you think are some reasons why we might use topical lidocaine? Any therapeutic uses?
To numb the skin first, IVs for kids, or...
Okay, so that's a big one. So we use that a lot in peds. So we'll use it to numb up sites for IV placement. And again, if you think about it, like if you're looking at how long it takes some of these drugs to kick in, because obviously if I put something on top of the skin, it's going to have to travel through the skin in order to have its get to its site of action, right? And so you have to look at things like lidocaine. Can sometimes take up to 45 minutes to an hour before you really see that basically the absorption occur and then the deadening of those nerves. Because it's a little bit more hydrophilic, it takes longer for it to get to its site of action to really have its effect. Yeah, so that's one big thing we'll do, especially kids that have a lot of IV access being done. They have ports that are placed. Oftentimes we'll numb up those areas, and frequently we'll actually tell parents before they bring their kids in, hey, go ahead and put their Imla cream on or put it in on their Elamax. And I'll talk about those products a little bit later. Put that on the site so that way by the time they get to the ER, get to the clinic, they can go ahead and just, the site's nice and numbed up and they can get their access, right? So that's a big one. Where else might we use it?
Dental procedure.
Okay, so we can use it, well, so just topical administration. Yeah, so you can sometimes use it for things like, yeah, so like have like benzocaine gel you can use for like toothaches, and sometimes you'll see it used for like aphthous ulcers or like cold sores and things like that. So that's certainly one place you can use it. You guys have heard of lidoderm patches? Right, so sometimes you can use that for kind of local neuropathic pains. You'll sometimes see those being used. That's all requiring that transdermal absorption of that. You know, the oral products is more kind of mucosal absorption that's happening there. So that's a little bit faster acting. You would see if it was just transdermal. And then on the other hand, you have the injection. So again, a lot of these are going to be either subcutaneous or intradermal injections that you're doing there to kind of deaden those fibers. Again, you can do epidural or subarachnoid spaces as well. It could be another site of action. So again, a lot of your epidurals are going to include ropivacaine as a very common one. But again, bupivacaine is another good one for using things like, you know, nerve blocks after like hip replacements. That's a pretty common one. And then is there any reason why we'd give IV anesthetics? Surgery? So again, injecting the anesthetics right into the vein.
Yes, we could put a tourniquet and then inject it to numb the whole arm.
Is that okay? So you could do something like a Beer's block kind of thing and numb up the arms. That could be one reason. The other thing is, if you guys go back to your antiarrhythmic lecture, you guys remember if any anesthetics popped up there? Lidocaine. Lidocaine can be used as an antiarrhythmic, right? So sometimes you can use IV administration of these drugs and actually block the sodium channels on the heart in order to help block some of those arrhythmias and get a normal cycle going again. So it could be another side of action. So I know you guys probably pushed all that out of your mind by now, but it's still there.
I think I asked Dr. O about why they don't use Lido and instead they use like, I think it was like some other drug that gives a lot of side effects. So how come they don't use Lido?
For
the heart,
mainly because it has to go back to efficacy, and so you're going to find that lidocaine it has its own toxicities associated with it, right? But you're going to find that this is more for like kind of emergent situations. Like amiodarone is usually the other one that we're going to go. Yeah, when we talk about ACLS, when we get to the ER section, we'll talk more about amiodarone. Amiodarone is really good for a lot of different types of arrhythmias because it's one of those. You guys remember the class that amiodarone is? What antiarrhythmic class? 3. It's class 3, right? Because it's blocking potassium channels and things like that. You guys remember which one lidocaine is? It's a 1B. Yeah, it's actually a 1B. Remember, 1A is your PDQ. 1B includes lidocaine, mexiletine, things like that. So amiodarone can be used for kind of a wider range of arrhythmias. Yes, it does have a lot of toxicities, but a lot of those are more kind of chronic. And so what you find is a lot of patients will get started on amiodarone, say like if you code it or something, we start on amiodarone and then actually get you on like eventually transition over to oral. So it's better for more chronic management of those arrhythmias. A lot of patients are not going to be able to use lidocaine in the long term because one, it's not systemically absorbed from the GI tract. So that's why one, we can give viscous lidocaine, you know, to kind of numb up the mouth. You don't see a lot of systemic toxicity from that. It doesn't get absorbed very well. Yep. It's a good question though. Yeah, but in general, you want to avoid giving a lot of these local anesthetics IV because especially things like bupivacaine, if that gets to the heart, you're going to have some big problems. We're going to talk about that just a little bit later. So how do we choose a local anesthetic? Well, you want to base it on the duration of action that's needed. So again, if it's going to be, you know, something like, you know, a finger like we do at the ER, a lot of times, like, you don't want the patient to have to feel that for the next couple of days because it's going to be sore. So, you know, you can use things like bupivacaine that sticks around for longer. Or if it's something like a very kind of transient amount of pain, so something like, you know, an IV stick, we can use things like lidocaine that's not going to have to stick around for quite so long. So you can think about the duration of action, what you need when choosing things. Short-acting ones, usually things like procaine or chloroprocaine are very common short-acting agents. We don't see those used too commonly. I probably see procaine more used like in the eye occasionally. You can guys go back to your ophthalmology lecture to see some of those local anesthetics we used in the eye previously. Intermediate acting, lidocaine is going to be one of the big ones you see used here. We'll also use prilocaine, usually a mixture with lidocaines occasionally. And then for the long-acting ones, this is where you run into bupivacaine, ropivacaine are probably the most common ones. I see these used more in the surgery realm more than anything else. You know, lidocaine gets used occasionally for, especially if you're doing things like LPs, so if you're doing a stick there, IV sites, things like that. But for actual like surgical purposes, ropivacaine, bupivacaine are probably the more common ones I see getting used frequently. Tetracaine is another good one that can be used in the eye. Again, if you're having to do a procedure there, you know, fluorescein stain or things like that. Occasionally you'll run into some combination products, and this can be useful. So again, if you're looking at things like lidocaine and bupivacaine mixtures, so there's a product called Duocaine, what you end up finding is that lidocaine can end up kicking in a little bit faster than bupivacaine, just clinically that's what you end up seeing. And so lidocaine will kind of kick in sooner, and the bupivacaine will last a lot longer duration of action. And so that can be a useful combination there. And then we have this EMLA cream. You might hear that term. That actually is an acronym that stands for the eutectic mixture of local anesthetics. Does anyone know what a eutectic mixture is? Probably not. There's no big chemistry nerds here, but basically what it means is that if you're looking at lidocaine and prilocaine, those two products can be a solid at room temperature. If you end up mixing them together, they actually lower each other's melting point, so they actually form a much more kind of a liquid type substance. And so by mixing those two together, they actually will go into solution essentially, and so you can get this EMLA cream. So minor point in case it ever comes up for trivia, but that is another very commonly used that for topical application for things like IV sticks and whatnot, or port access and things like that. So looking at the toxicity that you can see with these anesthetics, again, this is typically going to be followed after the absorption of the local anesthetic occurs from the site of administration. And the big things you're going to be noticing are going to be direct neurotoxicity and then also cardiotoxicity are the main ones. And so we can also have issues where the direct neurotoxicity can occur if you have high concentrations that are administered, say like in close proximity, say to the spinal cord. Say like you're doing an epidural and the placement's incorrect, that can lead to major nerve trunks being deadened by application of those kind of high concentrations there. Some of the CNS toxicity that you can experience, again, if you're seeing kind of excess sleepiness, you have lightheadedness, sometimes you'll have like auditory and visual disturbances that are happening there. And then the big thing you worry about is kind of the agitation, restlessness, and then eventually seizures can occur. Because again, if you're blocking those sodium channels, eventually that can lead to some kind of aberrant signals starting to act up, and that can lead to seizures. So we do worry about that. Some of the things that kind of key you in that the patient might be getting too much of their anesthetic includes things like tongue numbness and a metallic taste. So again, if I was giving you, say, like an epidural, and all of a sudden you start to experience that, that may be a key that, hey, they're probably getting too much of this systemically, and we go and dial back the dose. And then obviously more concerning things, you start to see nystagmus, muscle twitching, and then obviously seizures. That could be a bad sign. You probably want to stop your drug at that point. Other things you can see, so the cardiovascular toxicity is a big one we worry about, especially with your long-acting agents like ropivacaine and bupivacaine. And so basically you can see this manifest by systemic hypotension and arrhythmias. You probably see that bupivacaine is going to be more cardiotoxic than a lot of the other agents, especially just due to its long-acting nature. Because it is so lipophilic, it likes to sit there on those cardiac sodium channels and just sit there and prevent, cause these wide complex arrhythmias. And basically you can have patients that just, if they all of a sudden just go into ventricular arrhythmia, or they just go into PEA. A lot of that can be traced back to the bupivacaine. And so that's why in a lot of order sets you'll run into, if you're working in the hospital dealing with bupivacaine, they're going to always have PRN orders for a drug called Intralipid. You guys know where we normally use Intralipid? We use it for total parenteral nutrition, yeah. So this is how we provide fat for our patients when they are getting IV nutrition, right? Because normally they'll have a bag where they get their protein, their sugar, and their electrolytes, and then they'll have another bag that has this Intralipid, which is basically just a 20% fat emulsion. So they can get all their fats from that. But what happens is that because bupivacaine is such a lipophilic drug, it's sitting on those cardiac channels. When you give them a big bolus dose of this Intralipid, basically it provides the drug another kind of fat layer within the blood, and the drug is able to partition off of the sodium channels in the heart and actually partition into that Intralipid layer. Okay, and so it's very interesting. If you ever go look up the studies, there's a guy named Dr. Weinstein that did a lot of the original studies with this, where basically he would take these mice and had these little mice hearts set up, and basically he would inject bupivacaine, the heart would be beating, inject bupivacaine, flatline, and then all of a sudden you give the Intralipid and just start beating again, right? So it's kind of cool if you ever look at the studies, but there's a lot of research into this for using it for other potential tox sort of reasons. So there's a lot of interesting case reports where patients were overdosed on amitriptyline or something, which is another lipophilic drug, and we give them Intralipid while they're coding. All of a sudden they come back to life, and so pretty dramatic case reports are out there. So anyway, so this will be the reversal agent for local anesthetic-induced cardiotoxicity. So again, yes, sir.
Do you have to worry about a fat embolism or anything?
So that is a concern if you're giving really, really big doses. This is usually kind of a more transient type of thing. So typically you give like a big bolus up front. And again, this is really hard to give those big boluses because again, it's a kind of a thick solution. So you're trying to like push it as hard as you can. Only done it a few times in the clinical world, and it's always been kind of a logistic nightmare. And then you give a pretty rapid infusion for probably the next 30 minutes to an hour, and then hopefully you kind of gotten the patient over the hump, started metabolizing some of the more of the drug, and hopefully they're kind of through that. But yeah, so you always end up seeing a ton of your labs get screwed up because again you have such triglycerides are obviously going to be kind of through the roof. They can screw up a lot of the other kind of calorimetric assays and things. So very interesting. But again, this would be, and you're going to see this has been pretty much adopted across the board by anesthesiologists and other practitioners as this is the drug you go to if you were to have cardiotoxicity from these drugs. So another kind of interesting thing, sometimes you can see methemoglobinemia. So you guys know what that looks like? Yeah, patient looks like a Smurf, basically, right? So this is a big one that you can see with benzocaine. So benzocaine is very frequently used as an oral anesthetic, used a lot for teething pain, used a lot for other kind of oral sores and things like that. So basically what happens is you end up oxidizing the hemoglobin in your blood. Instead of binding to oxygen, it likes to bind to water instead. So it kind of takes on this very dark kind of color. Looks like chocolate colored blood if you ever get a venous stick and it looks like a chocolate blood. That's usually where that's coming from, is methemoglobinemia. They'll look very cyanotic, but they're breathing probably pretty normally. So again, it's usually you see a cyanotic patient, you're pretty worried about them, but this is kind of a less worrisome as long as the concentration doesn't get too high. But anywho, this is one of the things you run into. So we'd have sometimes people would use their cocaine. They thought it was really cocaine, really had a lot of benzocaine in it, so they'd end up coming in all blue like a Smurf. But the other big problem, and I'm kind of experiencing this right now, is teething children. It does not take very much benzocaine in order to really get a kid toxic. So if they were to get into it, eat a bunch, this could definitely lead to this methemoglobinemia. So that could be a thing you could see.
Do these patients sat out with their pulse oxes the same or different?
What's interesting is that the way that the pulse ox is going to read, and again, it's trying to differentiate between the light absorbance of oxyhemoglobin and deoxyhemoglobin. This tends to look more like deoxyhemoglobin, so their pulse ox might actually read falsely low, and actually will cap, or the lower limit's usually 85%. So if you have your patient and they're breathing, look like they're breathing normally, they look pretty comfortable, they're just blue, and you get the pulse ox and it says like 90. that may be false. It could be related back to the methemoglobinemia that they're experiencing there. So that is definitely a problem you can run into. But how do you reverse methemoglobinemia? When you have a blue patient, you give them the blue drug, right? So you give them methylene blue, and that would be the reversal agent for that one. Basically, it helps to allow you to kind of reduce back down that hemoglobin, so that way it's able to bind to oxygen again. Patient will pink right up. We'll turn all of their secretions blue and things like that. But actually, I had one patient who, you guys heard of the drug Azo, right? So where do you typically use Azo? Yeah, use it for UTIs as kind of a urinary anesthetic. That also can cause methemoglobinemia in large doses. And so we actually had a patient, phenazopyridine is the generic name. We had a patient who had overdosed on that. And so do you guys know what color Azo turns your urine? Turns it orange, right? So we had a patient who had overdosed on their Azo, had orange pee, so they had a Foley catheter in at the time, so it had orange pee, and you can see it coming out. And then they had this methemoglobinemia. It was probably around 15, 20% or something like that. So it's somewhat significant methemoglobinemia. You know, it's 20% of your hemoglobin that's now binding not oxygen but water instead. So we ended up giving her methylene blue to reverse that. So then all of a sudden her pee turns from orange to purple, because they had blue and the red mixing together and end up turning kind of purplish. So it's kind of fun to see that just in the Foley just kind of pour out, and you're just like, oh, interesting. Anywho.
Doesn't methylene blue have MAOI properties?
It does have some MAOI properties.
Does that get problematic with the amount of medicines patients already on?
It can be, especially because especially for like methemoglobinemia, it's like a one-time dose. It's not usually such a big problem. I did see a case of this occur. I probably mentioned it to you guys, but sometimes they'll use it to stain the parathyroids because it preferentially accumulates there. And so they were doing that. The patient was on, you know, whatever drugs they were on beforehand, so SSRIs probably, and so they did not take that into account. So the patient ended up developing serotonin syndrome in the middle of surgery. You know, so they started getting hyperthermic and hypertensive, tachycardia. They're like, what the heck's going on? You know, also like the other thing you're thinking about, they're in the middle of surgery. They're giving them general anesthetics. What else are you concerned about? They're intubated. See, we're about malignant hyperthermia, right? Remember we talked about that one? Yep, so malignant hyperthermia would also be under differential at that point. Patients heating up, they're getting hyperthermic, you know, hypertensive, tachycardic, like you're thinking, oh, okay, do I need to get out the hyperthermia cart and get, you know, the dantrolene and all that stuff? So, you know, I was considered, you know, your differential diagnosis, and once that was kind of ruled out, then the only kind of smoking gun was the methylene blue with the SSRI combination. So yeah, so always keep those things on your mind. Okay, moving on. So there's kind of two delineations of anesthetics you're going to run into. So there's amides and then there's ester anesthetics. Okay, this is important when we're talking about allergies, because you may have people that say I have a Novocaine allergy. What are you going to do with that? Okay, so the amides are going to be lidocaine, bupivacaine, mepivacaine. You'll note that the thing that they all have in common is they have an I before the cane. So if you're looking at an amide anesthetic and it has like lidocaine that has that I right before the cane, then you know that's an amide anesthetic. Okay? Everyone with me so far? When we're looking at the other ones, for your esters, notice they have no I's before the cane. So things like procaine, your tetracaine, cocaine, benzocaine, all of them fall into this category of the ester anesthetics. Okay? Unfortunately. But so if you have a patient who had an allergy, again, most commonly you're going to have patients have allergies to the ester class of anesthetics. Okay, the nice thing here is that the cross-reactivity is fairly low between the two. So for instance, if I had a patient who said they were, you know, they had received benzocaine and they ended up getting you know, anaphylaxis from that, you could give them lidocaine and they would have a very low chance of having any kind of cross-reactivity with that, again, due to that ester classification of the drug. Okay, so it's important to remember that a lot of patients, to them, all anesthetics are Novocaine, and notice Novocaine is a brand name, so that a lot of times you don't know necessarily what they're referring to, so sometimes you have to be a little bit, you know, dig a little deeper to try to figure out what specifically they had a reaction to, or if you have their medical records or things like that. That can be very useful, because again, you know, they say, hey, I'm allergic to anesthetics, like you don't want to lose that whole class of drugs, right? You want to still be able to use them if you need to for their given procedures and whatnot. Oh, another big thing to worry about, so benzocaine also typically comes, you guys have heard of hurricane spray? So hurricane spray is sometimes they'll use it, I guess from the RT standpoint, you guys used it a lot for You guys never used very much of it? Sometimes I'll see it like prior to like bronchoscopies and things like that. They'll try to use it to numb up the back of the patient's throat to sometimes kind of limit some of that gag reflex that can occur there. So it's a benzocaine spray basically, but that's a very common source of medication errors because again, usually the provider will write how many seconds to spray for, and then if the nurse or whoever's giving the drug is not looking at that, they just go and until the can's empty practically, and then all of a sudden the patient's got methemoglobinemia. So that's a very common source of that. So be very careful when using hurricane spray and not to spray too much drug. Otherwise, the patient will be certainly will be numb, but they'll also be blue. You don't want to do that. Okay. So again, looking at just a couple of the different products here, just note that there's obviously going to be differences in basically how their duration of action is going to how long it's going to last for. So lidocaine being pretty short, bupivacaine being a much longer one. You can end up seeing the benefits there for several days in some cases if you're doing kind of a local injection of things like bupivacaine. Again, this is just for your reference. You can kind of go back here and look at the some of the differences between them. And again, cocaine is very nice because it has those vasoconstrictor properties already built into it. So, real quick though, is there anywhere you do not want to use your vasoconstrictors? So places you don't want to use lidocaine with epinephrine. So see the fingers, the nose, where else?
Fingers, toes, hose, and nose.
What's a hose?
Thank you. We had to ask that too, and people thought we were joking.
That's weird.
Right?
It's crazy. Oh. Oh. Yes. Anywhere with terminal kind of blood flow, you don't want to give vasoconstrictors. And why is that? Why do you think? You can limit the delivery of oxygen because you're limiting blood flow to the area, so you can end up seeing tissue necrosis, gangrene. Now, clinically, I don't know how often that would actually come up where if you injected lidocaine with that being to the finger, it would automatically just fall off from gangrene. It's probably not going to happen, but in general, it's a thing you want to avoid. So very frequently, you know, if you're dealing with, say, like a lip laceration, that one's totally fine. You can use lido with that being no problem. If it's something like in the nose, again, probably want to avoid epi in those situations. Fingers, toes, the hose. Yes, just go ahead and avoid epi in those situations. Okay. Okay. So another thing. So you guys remember how so frequently lidocaine comes as a concentration, say like 1%, 2% lidocaine, and I mentioned there is a max dose associated with giving these anesthetics. You want to give too much, you can see cardiotoxicity and CNS toxicity. So if I were to say, okay, I have a 1% lidocaine, my max dose is 5 milligrams per kilogram. Do you guys know how to figure out how much lidocaine you can use? This question comes up very frequently in the ER. Nurses, paramedics, docs, all asking. It's good if you can figure this out. So when you said 1% lidocaine, how many milligrams per ml is that? Right, so again, you just move the decimal place over one spot from that percentage. So lidocaine 1% is 10 milligrams per ml of lidocaine. Okay, so now all of a sudden, if I said, okay, well, your max dose is 5 mg per kilo, you know, say it was for instance, let's say it's a 100 kilogram patient, right? Our max dose right at this point is 500 milligrams that we can give, and so that's how much lidocaine. Yeah, basically 50 mLs, which hopefully you're not having to use 50 mLs of lidocaine, but you can do the math, right? So just remember how to get from percentages to milligrams per ml, and then you can figure out what your max dose is going to be for those patients. Okay, it's a very handy trick you can use, make them up on your rotations. Anywho, moving on. One thing that we had not covered previously, but I might as well talk about it now, is going to be some sleep agents. So sleep is going to be a frequent complaint that you have coming to you. A lot of people have sleep-related issues, especially if you have any sort of infant in the bed with you. They oftentimes will roll and kick you and all those sort of things. But a lot of patients, especially older patients, end up having issues with sleep as well. So some common reasons for insomnia also include things like psychiatric disorders, especially a lot of anxieties and things like that can creep up when you're trying to get to sleep. Psychosocial stressors, excessive alcohol intake can actually cause issues with this. You may think alcohol is a CNS depressant, but again, you can lead to some sleep problems. Caffeine, nicotine use, so lots of things can be affecting your sleep, obviously. So, obviously for your patients, we like to use as few drugs as possible, so sleep hygiene is always a good thing to recommend to your patients. Things you can do, recommending normal times to go to bed and wake up. I even see that one of the iOS updates had a thing where they have like a kind of a bedtime trainer built into it where you can kind of set your bedtime and wake time, and it would try to get you into a more regular sleep pattern. One of the things I always thought was important is make sure the bedroom is really only used as a bedroom. So again, when I met my wife, she used the bed as a frequent space for just being on the phone all day long. That's totally fine. That's up to her. But you know, like sometimes she can't get to sleep at night. Crazy, especially when you have that like bright blue light flashing right in your face. You know, so again, this is one of those things where a lot of blue spectrum light can sometimes interrupt your sleep, avoid naps, things like that. So all these things that your patient should be doing first. But if those are still not working, then we can use our medications. So the idea of using some of these sleep aids is to, one, correct the underlying sleep complaint. So if the problem is that they are super anxious about whatever it is, like get their anxiety under control first, right? That's always going to be the kind of the first goal here. Try to consolidate their sleep into kind of one big rest period, and they're not waking up consistently. And you're going to find that some patients have problem initiating sleep, and then some of them are going to have problems maintaining sleep. Some can have both. You're going to find that based on which complaint they're having, we can tailor our drugs to suit that a little bit better, right? Hopefully we can improve their daytime functioning and avoid any adverse effects from the medications. And as you might imagine, what's a common adverse effect for some of these sleep aids? Yeah, daytime drowsiness. So that's going to be one of the big problems you run into. So if you're trying to make them so that they're more awake during the daytime and you give them drugs that make them more sleepy, that's not really doing anyone any good, right? And then for these drugs, you want to use the lowest dose possible for as short a time as possible, okay? Again, a lot of these are going to be controlled substances, and so you want to, you're going to have tolerance that can develop these drugs over time, so this is why I like to use very limited courses if at all possible. First off, we can utilize things like our antihistamines, right? Is there any antihistamines you don't want to use? Well, your second generations are not going to be any good, right? Because why are the second generations not good? Exactly, don't cross the blood-brain barrier, so they're not going to really get to the site of action. So I can take Zyrtec all day, probably not going to end up getting very sleepy off of that, right? Some people may be a little bit more sensitive to it than others, but things like Claritin, Allegra, probably not going to cause a whole lot of sleepiness. Okay, your first generation, that's where you're going to get that. So the very common one you see over the counter, what's a common one you see frequently? Benadryl can be used for sleep. What else? Unisom is another common over-the-counter brand name. So doxylamine is the first-generation antihistamine in that product. But things like NyQuil has chlorpheniramine in it. So keep in mind, a lot of these products are combination drugs, right? So you need to be careful with things like Tylenol PM. It's very common where they'll use that for sleep and they end up potentially getting too much Tylenol in their system, right? So they're having pain during the day, they're taking their hydrocodone, oxycodone with acetaminophen, and at nighttime they're taking Tylenol PM to sleep. You can see where the problems can start to creep up from that standpoint. Yeah, but diphenhydramine, doxylamine, the most common ones you're going to run into. You typically find that these are less effective than your benzodiazepines to initiate sleep, but they can be useful if you just need the patient to get a little drowsy prior to that. Be careful with the anticholinergic effects in your elderly patients too. That can be problematic. It can worsen dementia in some patients. It can lead to dizziness, orthostatic hypotension and whatnot. So just be careful in your older patients. These are probably not the best drugs to go with for that patient population. Sometimes antidepressants can be used. You'll find that the antidepressants, especially the TCAs specifically, have antimuscarinic properties, and so these are also going to be kind of drowsiness inducing, right? Trazodone is a very frequent one that you'll see prescribed for sleep, and this is one thing I saw that a lot of mid-level practitioners, so ARNPs, PAs, would prescribe trazodone for sleep because it's a non-controlled substance, right? So you guys won't really run into that problem so much, but that was a common prescribing practice, is use trazodone. They didn't have to get a special script for it or anything like that. You could just call that one right in. Do you guys remember the special side effect you're worried about with trazodone? Has to do with the hose. Priapism, yeah, priapism is a big one, right? Also, hypotension due to the alpha blocking effect. So, again, remember that's one of the things you can end up seeing with that drug in particular. Keep in mind that these drugs are also good for patients with substance abuse issues because they are non-habit forming. They are not going to be controlled substances, so these are probably better in that patient population than some of our things like benzodiazepines and other drugs like that. Okay. Another one that is a little bit newer drugs, suvorexant or Somra. This one is actually working through a different mechanism than you'd see. So no antimuscarinic properties here, but really they're working on this orexin A and B. Basically, they're antagonizing those receptors. And so what you're going to find is that the orexin has to do more with kind of like daytime wakefulness than it does sleep necessarily. And so basically, it does not induce sleep for these patients, but it turns off kind of like the wake signaling that would normally occur. So sometimes you may see this being used for better for patients who have like kind of shift work disorder, right? So like my sister is an ARNP and she's been working overnights in the ER for the past, I don't know, 15 years or something. But you know, she has lots of sleep problems, so she's tried pretty much every drug under the sun. But this may be one option you can try for those patients. Good for initiating and then maintaining sleep. And then looking at adverse drug reactions, you're going to find that somnolence is going to be a big common one across most of these. But some of the other kind of interesting ones with this drug in particular, things like sleep paralysis. Sounds fun, right? Nope. Cataplexy, narcolepsy-like symptoms are possible. So again, this is probably a drug to use as more like a second and third line type agent if they've kind of failed other things first, but is one you may see used out there. There's another drug called Ramelteon or Rosarum. I think this is the one that had like the Beaver and Abe Lincoln commercials. They were pretty good. If you guys ever YouTube those, they're kind of funny. This drug is, again, different mechanism here. These are actually going to be working on the melatonin receptor agonist. You have these two receptors, MT1 and MT2, melatonin receptors, and these are really thought to help regulate things like circadian rhythm, sleep onset, and things like that. So really trying to establish kind of like a more normal cycle for your patient. And so this is really good for sleep onset issues, not necessarily great for maintaining sleep throughout the night, right? So if the patients have a problem initiating sleep, this is a good drug for them. Again, melatonin can also be used as a common herbal supplement. Again, my caveat with herbal products is make sure you go with a high quality reputable brand, not something that's just like, you know, I got it at the gas station kind of melatonin, like, you know, you have no idea what's in those products because they're not as tightly regulated as you'll find with FDA approved products. So just be careful with those. Make sure your patients don't necessarily skimp out on their herbal supplements, and let them make sure they're telling you if they're taking other things as well, because again, if you were using melatonin plus this, you can end up running into some potential problems if they're kind of working against one another or seeing toxicities from that. Okay, so then you have your benzodiazepine receptor agonists, and so all of your benzos that we've talked about previously could potentially be used for initiating and maintaining sleep. Obviously, there's a big differences in how long they're all going to have to be working. Some of them are very short acting, some are long acting, some have active metabolites. And so what you're going to find is that they have a subset of benzodiazepine-like drugs that we use nowadays that are more kind of custom tailored for helping with insomnia. Basically, they're you know, durations of action are shorter. They don't have active metabolites in order to help make sure that you sleep for the 8 hours that you're supposed to, and then when you wake up, hopefully you're going to be nice and ready to go at that point. But keep in mind that all of these are going to be causing physical dependence. Addiction is definitely possible, and they're all going to be scheduled for drugs, right? So they're all controlled substances from that standpoint. Also, they have a warning on them from the FDA about some nighttime behaviors that could occur while taking these drugs. So again, if you ever hear one of the common ones is called Lunesta. I don't know if anyone's had experience with themselves or friends who have experienced Lunesta, but my wife had a roommate who was using Lunesta, and she cannot use it ever again because she ended up having all kinds of weird like nighttime like wakings, and she would go and like order things online. I have no idea why stuff showed up from Amazon like 2 days later, and you had no memory of whatsoever, right? So going through and like you can actually see a lot of weight gain associated with this because people will go and sleep eat, they'll wake up and all of a sudden the fridge is completely empty. It's all related to them just not being conscious of what's going on while they're awake. Okay, so be careful of that. Make sure that if possible, have someone else report back if they're having any of these issues, because this might not be good drugs for them in that situation. Also, do not use these with other CNS depressants because they'll have certainly synergistic effects. So ethanol being a very common one people use to help them get to sleep. Don't do that. And then don't use it in pregnancy. These are going to be teratogenic, so you don't want to use those. Category, I believe category D. History of substance abuse, because again that can lead to potential tolerance, addiction, abuse of these drugs. And then why not sleep apnea? Why do you think that would be one to avoid? Exactly, yeah. So again, if this causes any kind of respiratory, usually benzos are very safe. Usually you don't see a ton of respiratory depression by themselves. But if you already have a kind of mechanical obstruction already occurring, you don't want to blunt that respiratory drive any further. So you can see some problems with that. So that's why we avoid that for those patients. So basically what you're going to find is that high doses or long half-life agents are more likely to produce daytime drowsiness, right? So long-acting agents are no good. Things that have active metabolizers are more likely to cause daytime drowsiness. You don't want to cause that. So, and keep in mind, tolerance will develop over time, so they may need to adjust their dose up if they are having to use these for long periods. Rebound insomnia is going to be the major side effect here, especially if they come off of it kind of cold turkey. They've been on it for a while, so you do want to titrate your dose down if they've been using it for a while. That way they give the GABA receptors time to kind of re-equilibrate and start to upregulate again, since they've been kind of having this constant activation over time. And then the 3 non-benzodiazepine GABA-A agonists, so these are kind of our non-benzos, as I call them. And they call these the Z drugs. So you have zolpidem, zaleplon, and S-zobiclone. Those are the most frequent ones we use. And these are marketed specifically for sleep. Okay, both sleep initiation and maintenance of sleep. Okay. So just to kind of give you an idea about some of the comparison between these here, you're going to see that there's a couple of other benzodiazepines that are included on this slide here. But if you're looking at things like some of your shorter acting benzos, things like temazepam and triazolam have pretty short duration of action. Actually, the half-life for temazepam is kind of long. This would be better for kind of like maintaining sleep throughout the night. But things like triazolam, very short duration of action, better for kind of initiation, right? Focusing. I'm going to the wrong slide. But anyway, if you look back at the Z drugs, you'll see that some that have longer half-lives, those are going to be better for maintenance of sleep. Those that have shorter half-lives are going to be better for just that initial initiation, and then hopefully lead to less daytime drowsiness. Okay. All right, we'll just finish up this section and I'll let you guys go on break. A few other drugs you'll sometimes see being used are called modafinil and armodafinil, or Provigil and Nuvigil. These are approved for excessive daytime sleepiness, and these are really marketed towards those shift work disorders or narcolepsy. You'll find that used a lot for narcoleptic patients. The mechanism of action, we don't actually know why it works, but it tends to work for these patients. And you notice that they're pretty well tolerated for the most part, but they, for whatever reason, happen to be a C4. I've never heard of anyone abusing these drugs other than just to help them sleep a little bit better, but they are still considered a controlled substance, so just be aware of that.
They keep you awake. They don't make you sleep.
They help you to kind of regulate when you sleep and when you're awake. So for instance, like my sister would use it. She would go on a long stretch of overnights, and then when she was coming off of that and have to get back on a normal sleep schedule, it was very difficult to do that for her. And so she ended up using this drug in order to help kind of regulate when she sleeps a little bit better, try to get her circadian rhythm kind of back on track. Yep. So it's a very common problem you run into with a lot of patients, or a lot of people who work overnight. They can run into big sleep issues, right?
When do you take it? Before you go to bed or when you wake up?
It lasts long enough that you just take it. I would probably recommend taking it before bed, and then it should kind of last you throughout the day. Hopefully, get your limit a lot of that daytime restlessness. Yeah. Okay. So, any questions on that section? Yes, ma'am.
I went to a talk once for Belsomra, and the speaker was talking about how some people take Benadryl to fall asleep. It can cause like short-term dementia. Do you know anything about that?
Not dementia necessarily. It's probably your older patients who would be more at risk for that.
It was like people who consistently use it for sleep, like it can cause like, dementia that could be reversible, like something like that.
Yeah. I don't know of anything like that specifically. Certainly you could develop some tolerance to it, and so it's hard for patients who have used it for a long time to go to sleep without it, you know. So that can be one thing, but I've not heard of dementia specifically. So it could be one of those things that's kind of either underreported or it's just a small number of patients experience it. Any other questions? Okay, you guys are sleepy enough. I'll let you guys go on a 10-minute break. We'll come back and continue on the ER stuff. Any questions from the first half? Okay, so we're going to continue talking about our ER, emergency medicine kind of topics. Obviously, this is not able to cover every single topic, but we're going to talk about a few situations where we'll cover some new meds we've not covered previously, and a couple of emergent situations where meds are pretty important and we'll kind of cover here. So first thing we're going to talk about is rapid sequence intubation. Have you guys covered anything with RSI yet? All right, so I'll show you guys how we're going to manage these patients who need a tube down their throat, something fierce, right? Basically, this is a rapid process, as the name might clue you in, but it's a sequential process, right? And so you're going to find that, especially like, say for instance at Nemours, like this is a thing where a patient needs to be intubated. Usually it's a pretty, at least in the ER, it's usually an emergent type of situation. Like if you're in a surgical realm, if you're like in the ICU, it could be something you kind of see coming along and you can kind of prepare for and get ready for. Like in the ER though, a lot of times patients are rolling in from the ambulance, they need an airway quick and you got to do something fast, right? And so this is where a lot of things like checklists are starting to become more commonplace, where you want to make sure that when you do this, you do it the same way every single time for every single patient, because that's going to lead to better outcomes for them, right? And so it's really important that this is kind of a mechanical process, that you practice it. So we do a lot of simulations regarding RSI, because again, if the airway goes bad, like lots of things can go wrong. And so you need to, and obviously, you know, you don't have to do an emergency cric in the middle of the ER. That's always the thing we want to avoid, okay? This is why we want to get really good at this process. But basically, you're going to find that there's a preparatory stage, there's a sedation stage, and then finally there's the paralysis, right? So this is the main places where the medicine is going to be coming into place. Obviously, there are lots of things kind of happening all at the same time. You know, patients getting oxygenated, like we like to give them lots of oxygen, so that way we can kill a lot of the dead space and kind of fill up their whole airway with oxygen as best we can to give us time to get that airway placed. And basically the whole point here is we want to facilitate with our drugs is this emergent tracheal intubation. Before you push any medicine, it's really, really important you make sure you get a good history, or at least as good a history as you can get from these patients. You know, if they were found down by themselves and they have no prior medical history, I don't know, you got to go with the worst case scenario in a lot of cases. But if you can, try to figure out what allergies they have to medications if possible. Try to figure out if they have any history of neuromuscular disease. Okay, so that's going to be really important when we talk about one of our paralytics. It's really important you kind of uncover any of these medical problems. Small children can be a problem because they oftentimes may be undiagnosed for some of their musculoskeletal issues. This is things like Duchenne's muscular dystrophy. This is things like ALS, things like that. We'll talk why that's important a little bit later. If they have renal compromise. If they have a history of malignant hyperthermia, you do want to figure that out and see if anyone's had bad reactions to anesthesia previously or succinylcholine. You want to find that out. If they're asthmatic, and then also if they have any previous intubations or anesthesia, what were their responses to that? You know, there are certain drugs they do better with than others. These are all good things to figure out before you try to sedate them. So first thing we'll cover are the meds you use for pre-treatment in an RSI situation. And so typically you're going to find there's kind of pretty common responses to laryngoscopy for these patients. So some patients, they can either have their heart rate increase just due to kind of the physical stress of having this occur. Some patients get more bradycardic. You end up seeing kind of a vagal response to this, and so you can see their heart rate drop. You can see increases in intracranial pressure. Again, especially you worry about the gag reflex, especially the patient's gagging on the tube. That can lead to big jumps in their ICP, which can be problematic, especially if they're like a head trauma patient or things like that. See blood pressure go up, and then also potential for increased airway resistance and bronchospasm. Okay, so there's a couple medications that we can give beforehand for certain situations in order to help prevent some of these problems. First drug that we can give is lidocaine. We just talked about local anesthetics, and so this is a very common one that you can use. And basically, we can give this, and again, you don't have to memorize the doses. This is just kind of adapted from other lectures that I give, but good rules of thumb to have anyway, at least on hand. And again, this one's going to be given a few minutes prior to the actual intubation. Okay, because you're going to see that a lot of our drugs work very quickly. You want to do this about 2 to 3 minutes before you push any other meds. Okay. And so basically this kind of numbs up, blocks those sodium channels in the back of the throat, so hopefully prevents any of those gag responses, so that way you don't have any big jumps in their ICP, right, the intracranial pressure. So this is good for like trauma patients who you're worried about having, you know, they're having any kind of cerebral edema or any kind of cerebral swelling. These are good patients in order to receive lidocaine. Okay, even if you have like kind of a, if you're not sure what the patient, you know, what happened to the patient before they came to the ER, you know, if they're found down, you don't know if it's because they hit their head or if it's some other reason. This would be a case where lidocaine can be utilized. Okay. And so this will be important for test questions. So I might say, like, you have a patient coming in and they have this history. What drugs do you want to use for pre-treatment, right? And so if they have a history of head trauma or something, you're worried about ICP, lidocaine's a good drug to use. Okay. And again, usually you'll see it used as an antidysrhythmic. We'll see that in the ACLS section a little bit later on in this talk. But again, those anesthetic properties are good for blunting that gag reflex. That's going to be the main use we use it for there. The other drug that we use very frequently, or some frequency for pre-treatment, is going to be atropine. And again, this is going to be given 2 to 3 minutes or so before the intubation occurs. And you guys remember what type of drug atropine is? It's an muscarinic, right? So it blocks the muscarinic acetylcholine receptors, okay? So it's anti-muscarinic, and what's that going to do to things like your heart rate? Should speed it up, right? Because again, if you basically it's acting to block acetylcholine, you're blocking that parasympathetic nervous system, you're going to see increases in heart rate, okay? And so this is going to be important because, as I mentioned, some patients tend to get bradycardic. They end up having a vagal response when you're trying to put a tube down their throat. So this is one of those things where you can blunt that by giving atropine beforehand and preventing that drop in their heart rate, right? So especially you see this with very, very young children, so say like less than 2, they're more at risk for having this kind of vagal response. But you'll also find that other patients who tend to get bradycardic are those that receive multiple doses of succinylcholine. You'll see, I'll talk about this more in detail, but you'll sometimes see it referred to as SUX as a shortened phrase there. But succinylcholine can cause this in multiple doses. Hypoxia potentially, especially if the patient is emergently being intubated and they're hypoxic beforehand. So all could be reasons why you use an antimuscarinic to help kind of perk up their heart rate, allow for better cardiac output, better perfusion. Okay. All right, so those are the pre-treatment drugs that you can give. Say 2 to 3 minutes before the actual intubation occurs. Again, at this time, you're getting set up, you're getting oxygen for the patient. Again, you're making sure you're holding their airway open, giving lots of oxygen, you're getting these pre-treatment drugs on board. And then we have our induction agents. So these are the things that are going to be putting our patient to sleep. Notice how this comes before the paralytic stage, right? You never ever want to paralyze a patient who has not received sedation. You wouldn't want it done to you? Don't do it to your patients, okay? So the ordering of these drugs is really important from this standpoint. So next we have these sedation agents, the induction agents. I've talked about several of these already, but I'll talk about them in the setting of RSI and why we like to use the ones we like to use. So here's etomidate, or amidate is the primary one you're going to use probably for most RSI cases. You guys remember that from the surgery section, this is nice because it's very hemodynamically neutral. Doesn't really do anything to your heart rate, doesn't really do anything to your blood pressure, okay? So if you had like a septic patient who came in and they're already hypotensive, this is a good drug for them from that standpoint because it's not going to drop their pressure any further. The other nice thing is it's a very rapid onset, so in about 30 seconds to a minute after you push this, they're going to be pretty much knocked out, right? So very, very quick action, and then it only lasts maybe, say, 10-20 minutes for a single dose. They're going to come out of it very frequently, or very, very quick for the most part. And so why do you think it'd be important for having fast-acting medications like this from the sedation standpoint?
Emergent?
It's emergent. What do you want them? Why do we want them to have a short? Why don't we want to give them something that's going to last like 4 hours, 6 hours?
Assess them and let them go home.
Okay, so if they're being intubated, though, they're probably not going to be going home anytime soon. So that could be one thing. But you're absolutely right about the assessment part of it. So again, if you had a patient who you need to do like a neurologic exam on, if they are completely knocked out or if they're paralyzed for several hours, you're not going to be able to do a good neuro exam, right? So that could be one thing, especially if they're like a status epilepticus patient, they were head trauma, things like that. You want to be able to potentially assess their neuro status, right? And so you can't really do that if they're still completely zonked out, okay? That could be one thing. The other thing is if the intubation doesn't go well, you want the patient to be able to get their respiratory drive back. And a lot of these drugs are going to be able to are knocking out their respiratory drive completely, and then obviously the paralytics are going to be doing that as well, just by paralyzing the diaphragm. Okay, so that can be one of the things is that we want things that are rapid acting and that wear off fairly quickly. Okay, most often once these patients get intubated and you get them kind of settled, then at that point you're going to put them on sedation anyway, so that way they don't fight the vent. But that's going to come a little bit later on. So again, etomidate's working by helping to enhance the GABA effects. Again, they're not working as a benzodiazepine, it's kind of working at a different site there, but it enhances GABA, helps facilitate that inhibitory neurotransmitter to work a little bit better. And so again, it's all dose dependent, so you can give small doses to get kind of a light sedation, but the doses that we're giving are pretty heavy. We're going to be inducing pretty deep sedation for our patients, which is good because we don't want them to remember that they're getting intubated, right? And so, very similar to the barbiturates, which are another option you could potentially use for these settings, but etomidate tends to be the one we most commonly go with. No good contraindications to this. We're going to talk about contraindications of some other drugs, but the nice thing here, as long as they're not allergic to it, you can give it pretty much with impunity. And again, the main indication is going to be as an induction agent prior to neuromuscular blockade. Okay, so again, that's just another name for our paralytics that we're going to give. Some people used to use etomidate as a sedative agent for like reduction of like dislocated joints and things like that. so much due to some of the side effects we'll talk about, but one of those being kind of myoclonic activity. So again, if you're kind of tensing up your muscles and things like that, you kind of want the patient a little bit looser so you can get those joints back into place. So we don't really use it for that anymore. Really, RSI is the big place here. But again, nice thing here is rapid loss of consciousness. They're going to have rapid distribution to the CNS, and then it's able to redistribute out of the CNS very quickly as well. So that's why it works so quickly and comes off so quickly. You see the dose that we typically use there. Again, duration of hypnosis or the sedation here is about 5 to 10 minutes or so. This is going to be important, especially remembering how long agents are lasting when you need to consider, say if you have a few failed attempts at the intubation, if you need to give more drugs, right? Because again, these drugs don't stick around forever. So you need to consider, hey, it's been 5-10 minutes, like patients starting to move around, perhaps we should give them some more drugs, okay? So that's again the other caveat with giving these short-acting agents. Obviously, as far as drug interactions go, if you give them with other sedative agents, you're going to have some synergistic effects. So you may see the drug last longer than what you would expect. Could be related to other CNS depressants they've had. And unfortunately, no interactions with the neuromuscular blockers. So really kind of working independently of those paralytics that we're going to be pushing after our induction agent. Again, the side effects you worry about most in the setting of RSI is one that's trismus, right? So you don't want your patient's jaw to kind of lock up when you're trying to get them nice and open so you can put a tube down. So that'd be one thing that I unfortunately have never seen actually occur, but is one thing that a lot of providers are at least keeping in the back of their head. And you also see some myoclonic jerks, muscle twitching, and things like that, which can be pretty variable, but some patients are more prone to it than others. This will be important too, especially when we give one of our paralytics, because one of the paralytics can actually cause some of these same types of side effects. So you don't really know if the twitching is more fasciculations from one drug versus another, but we'll talk about that in a few minutes. The big thing you want to worry about, especially for patients who are septic or patients who are like in very high stress states, are the fact that etomidate, even after one dose, can drop your plasma cortisol levels. And so this can be problematic for patients who are septic, they're coming in hypotensive, and they're not really able to maintain their blood pressure very well. This can make that a little bit worse. So in some cases, you may need to give stress dose steroids afterwards in order to help kind of maintain their pressure a little bit better. So for instance, down in the ER, they get intubated with etomidate. They're up in the ICU, they're on multiple pressors, on lots of fluids, nothing's really working. Give them like a stress dose of hydrocortisone or something, and that helps to kind of replenish some of those cortisol effects you're missing. Okay. Hydrocortisone is usually the steroid we're going to use in that situation. Okay. You can also use benzodiazepines in order to get your patients into a state of sedation deep enough that you could do intubation. I find that these drugs are not going to be as widely used as something like etomidate, mainly because they take longer to work, they stick around for longer, and the actual sedation that you get can be kind of variable. So we were kind of talking about, like, depending on what patients, what their tolerance level is to things like ethanol, things like other benzodiazepines, they can be pretty resistant to these drugs, and so you may need even higher doses than normal in order to sedate these patients very well. So I personally don't like these too much for intubation purposes, but there are other drugs you may see used occasionally. The two big ones are going to be midazolam and lorazepam, right? Lorazepam, where do we usually use that IV for?
Calm down.
So you can use it for anxiolysis. What's the other thing we can use it for? Seizure, yeah, absolutely. That won't come across on the YouTube video, but I was shaking violently there. So seizure is the main place where you see lorazepam being used. And if you remember back to the kinetics we talked about, lorazepam being more water soluble or more lipophilic than some of the other benzos. It was more water soluble, right? So it took longer for it to get across the blood-brain barrier to get into the CNS, but also stuck around for longer, which is why we like it for seizures, right? Because they help to prevent recurrence of seizures after the initial one is under control. Midazolam, on the other hand, is a little bit more lipophilic, so it crosses the blood-brain barrier very quickly. Also doesn't stick around for as long. So if you're going to intubate someone with a benzo, typically midazolam is the one to go with, because again, it's going to have a little bit faster onset, and it's also going to get out a little bit faster than your lorazepam might. But nice thing here, it provides sedation, amnesia. If you had a patient who had status epilepticus, perhaps this is a good reason why you might intubate with this drug potentially, because it has those anticonvulsant properties, right? You can see the dose we're typically using here. Again, fairly rapid onset, probably a little bit longer to really kind of kick in than you see with like an etomidate. And again, sticks around 15-20 minutes or so. So you can expect to see kind of the residual sedative effect for some period of time. Again, some patients may have a decreased dose due to a longer half-life. So for instance, they have things like organ impairment, if they're obese, they're geriatric patients, or hepatic insufficiency. Those are all patients who might need a little bit lower dose because they can have the drug stick around for even longer. So just be aware of that. Okay. Another, again, favorite of mine is ketamine, or Ketalar is a common brand name you see for that one. Again, this is a good dissociative anesthetic, again, derived from PCP. Remember, do you guys remember the mechanism for that drug? Blocks the NMDA receptors, right? So instead of enhancing GABA, they're actually working to block glutamate instead. So that's why you can get a different kind of anesthesia with this drug than you would see with other agents. Again, this one's nice because it provides both sedative and analgesic properties, so that can be a benefit for your patient. The other thing is that it's going to cause that catecholamine release, so you can see increases in heart rate, increases in your blood pressure, and you will also have this bronchodilator effect. So again, it's good for patients with status asthmaticus. I just saw this on Friday. Like, young boy was, what did he have? I think he had an ulnar fracture that needed to be reduced, and so we ended up using ketamine for him. And sure enough, like, you give it to him, like, his blood pressure is probably like, say, 100 over, I don't know, 75, and you give it to him. A few minutes later, all of a sudden his blood pressure is like 120 over 85, right? So you're going to see those jumps in your blood pressure. You're going to see jumps in your heart rate. Went from, let's say, 130 to 140. There's very common effects to see for those patients, which can be good, especially if you had, say, like a septic patient who's hypotensive. This might be good to bring up their blood pressure a little bit due to those catecholamine effects. So again, status asthmaticus is a good case for this. Hypotensive patients is another good one where you might want to use ketamine. Other thing, leaves the respiratory drive intact as well. So for instance, if you ever need to do, say, like a conscious sedation, or if you need to do like an intubation. So the one weird case I saw this being used for an intubation was a guy who came in with angioedema after taking lisinopril. So comes in, and of course when you have angioedema, what happens kind of your whole airway tract and face? Everything's swollen, right? The guy's tongue is looks like it's freaking, it looks like one of those hot water pads that was, kind of sticking out of his mouth. And the thing is, like, you're never going to be able to visualize his airway with a typical laryngoscope because everything is just so swollen. You're never going to be able to get that tube down. So that guy, he was still able to breathe somewhat on his own, but we know he's going in the wrong direction. And so what they were going to do is actually put in a fiber optic scope through his nose, down, get it past his airway, right, and go through the vocal cords, and then slide an ET tube, a smaller tube, down over that scope and get it into the airway, right? So it has a guide that can go ahead and follow. So for that patient, because we knew that his airway was kind of precarious, we wanted to leave his respiratory drive intact, and we wanted him to at least be able to kind of work with us and leave him somewhat conscious. So we gave him a dose of ketamine. He was certainly kind of out of it at that point, but he was still able to kind of follow some commands, and we were able to get the scope down, get the ET tube on, and he was able to be intubated that way, right? So sometimes you run into weird situations where you need to use different drugs based on what the situation is. And so this is a good one. Also, because of the angioedema, it has bronchodilatory effects, right? Also good for that patient to help him oxygenate a little bit better. Okay, so keep the different situations in mind where you might want to use one drug versus another. Some problems you run into with ketamine is, one, it's a sialagogue, which is just a fancy way of meaning it increases saliva production. So you can sometimes see where, again, if you're trying to establish an airway, you have lots of secretions that can be problematic and kind of occlude your vision, things like that. So sometimes you have to give atropine to dry patients out a little bit. But again, good suction could also be used to kind of clear them out. Some people will not want to use this drug for patients who have elevated intracranial pressure because they're worried about the catecholamine effects kind of raising that up even further. So they probably want to avoid this for head trauma patients, not one we use very frequently. Obviously, dysphoric reactions we mentioned, more typically seen in adult patients. Hopefully, if you're intubating these patients, they're going to be maintained on sedation afterwards. You don't have to worry about that necessarily, but it is one thing to think about. And then vomiting is also another problem. So, aspiration risks from that standpoint. Then we have propofol, that milk of amnesia. Again, notice the base here. It's basically the same base as we saw with the intralipid. So it's put into that kind of fat emulsion to keep the drug solubilized. This one's also a very good drug for the fact that it's very short acting, very quick acting. The other thing to worry about, though, is it can cause hypotension, right? So in that septic patient who's already hypotensive, this can worsen that potentially, so you want to be careful with that drug. And then also ask if they have an egg or a soy allergy, because again, they can have a reaction due to the lipid emulsion that the drug is in. Okay. You guys remember what color it turns your urine? Green, yeah. got things that turn your hair in blue, orange, green today. I think we covered almost all the roads you've covered, right? Okay, so those are the typical induction agents you can see being used for an RSI. So again, think about you're oxygenating your patient. Usually try to do at least 5 minutes or so. Does that sound right? 5 minutes oxygen. You try to get 5 minutes, but a lot of times you find time dilation and contraction happens in these kind of emergent situations. So you're like, oh man, it must have been 10 minutes ago that I pushed that epi, and it's like it's been 30 seconds. So sometimes time can be a little funny when you're doing things like this, but. So you oxygenate your patient, you give them their pre-treatment drugs, say 2 or 3 minutes before the intubation, and then you push your sedative drug, usually give it about 20-30 seconds or so to really kind of start to kick in, and then we're going to push the paralytic. Okay, these drugs are super deadly. You need to make sure you have an airway plan in place if you're ever going to be pushing paralytics, okay? Because the patient's not going to be breathing on their own, so you need to do it for them. If you want to kill your husband, this is the way to do it. So I'm keeping an eye on my wife. I know what's going on. You gotta be careful when you marry a pharmacist, that's what I'm saying. So anyway, so basically we have a few different types of neuromuscular blockers that we're going to be using here. Again, neuromuscular blocker, just another way of saying a paralytic agent. They're working by blocking that natural transmission of nerve impulses to the skeletal muscle, right? So the big thing we're going to be focusing on is that acetylcholine transmission, right? So typically acetylcholine is going to be affecting the nicotinic receptors now in order on that muscle end plate in order to prevent transmission, and then you see the paralysis that occur here, right? So we'll talk about a few different types of paralysis. There's the flaccid paralysis, and we'll talk about the kind that succinylcholine causes. But the nice thing with these drugs is they have no direct effect on the heart, the digestive system, the brain, pupillary response, anything like that. Really, they're just affecting the skeletal muscle, okay? So also notice they have no effect on the level of consciousness of the patient or pain perception. So if a patient is not adequately sedated and they're paralyzed, they have no way to tell you that they are in pain or that they are uncomfortable or anything like that. So it can be very, very traumatic for patients, especially if they're in the ICU for a long time, they're paralyzed for a long time, they don't have adequate sedation, they have no way to deal with that, right? So you'll sometimes have patients who have like ICU dementia or ICU psychosis is a term you'll hear about. Some of it could be related back to the fact that they may have been over paralyzed and under sedated in some cases. So be curious about that. You guys know of any ways to kind of monitor for things like pain and whatnot if you're in a paralyzed patient? Yeah, heart rate's gonna be a big one. Blood pressure you can look at. So again, look at the, if they're like, why is the blood pressure, heart rate elevated? Could be related back to a pain issue that's going on. The other thing is there's no direct effect on seizure activity. So we worry about this from a tox standpoint. Lots of drugs can cause seizures. You worry about this in status epilepticus patients because if I give this to a seizing patient, what happens to their seizures? Right, the brain's still seizing, but their body looks like it's not doing anything, right? So again, this is one of those things where having a bedside EEG is sometimes necessary to monitor seizure function for these patients or seizure activity because of the fact that they're not going to be able to outwardly manifest that due to the paralysis you've induced. Okay. All right. I don't know why I did this, but the main ones we're going to be using, the first one's going to be this depolarizing neuromuscular blocker. It's called succinylcholine. This is the only drug that falls into this category that we use clinically. So succinylcholine is a depolarizing neuromuscular blocker. And then you have your non-depolarizing neuromuscular blockers. And so again, these are going to have a little bit different mechanism of action. This is going to include pancuronium, rocuronium, vecuronium. Those are the three main ones we're going to use, and then we'll talk about a few more a little bit later, things like cisatracurium, and we'll talk about, we'll mention pancuronium there as well, but the two main ones that you're going to be using with an intubated patient is mainly rocuronium and vecuronium from the non-depolarizing group, and then succinylcholine is a common one you'll see used RSI as well. So again, they're going to be classified depending on their mechanism of action and how they affect that neuromuscular end plate. Again, typically what you're going to find is that obviously acetylcholine is going to be released from the end of the dendrites onto the neuromuscular end plate, and normally you have to have that transmission of acetylcholine activating those nicotinic receptors to cause muscular contractions, right? That's going to be interrupted when we're giving these neuromuscular blockers. Basically, again, acetylcholine is just going to be produced from acetyl-CoA and that choline. Again, this is something that gets regenerated over time. We don't like to be wasteful in our bodies, and so as that gets broken down by plasma esterases, you can end up recycling that. And so those plasma esterases are going to be important because if you inhibit that, you're going to get more acetylcholine, right? And so potentially that can lead to either toxicities or reversal of some of these agents. If you have too little plasma esterase activity, or if you have too much activity there, you can end up seeing not enough acetylcholine. That can also be problematic. So it's important to make sure we have kind of a nice balance between the two. So just remember that process, because that'll be important when we're looking at how some of these drugs are working. Again, looking at succinylcholine, this is the only depolarizing neuromuscular blocker that we have in clinical use. The benefit here is it is very short acting and very rapid onset, right? And so we'll look at how that causes, and again, we call this a depolarizing neuromuscular blocker because of the fact that it's causing these fasciculations that occur due to its mechanism. Succinylcholine itself is actually just kind of looks like two acetylcholine molecules put together, and so that, again, it makes sense why it's going to be activating those same receptors. It also gets metabolized by these plasma esterases, very similar to acetylcholine. So some patients actually end up having a plasma esterase deficiency, and so those patients can actually have an extended half-life for succinylcholine due to the fact they just don't have as much enzyme to metabolize it. So some patients may have a shorter duration of action, some may have longer duration based on their plasma esterases, and then it gets eliminated in the kidneys afterwards. So kind of the two phases of the way that acetylcholine works specifically is that one, it's going to be blocking due to the fact that it has kind of prolonged stimulation of the acetylcholine receptor. So basically, because it looks so much like acetylcholine, it's going to go on, attach onto those nicotinic receptors, and activate it. Okay, basically by activating it and keeping it stimulated, it's going to initially cause the muscles to contract. Right, so this is why you see fasciculations occurring after you give succinylcholine. Right, so you can see twitches in the muscles shortly after giving it, and that's to be expected. So again, it's sitting on the receptor, activating, keeping it open, and preventing any further activation by normal acetylcholine. Okay. The next is actually going to continue sitting there on the receptor, and it actually ends up desensitizing the receptor to the fact where it gets so difficult to initiate a new action potential that the muscle is basically just paralyzed at that point. So it's not able. So then you end up seeing this flaccid paralysis. So again, with succinylcholine being a depolarizing neuromuscular blocker, it'll come in, activate those nicotinic receptors, cause fasciculations, depolarize those neuromuscular end plates, and then it's going to tire them out, and then they're going to be flaccidly paralyzed. That make sense? Basically, it's establishing like an infinite refractory period. So if you kept this drug around, the receptors themselves can never reset, and they also get desensitized to where even if I give a ton of acetylcholine, that's just going to end up even making it worse, right? So again, this will be different than when we see the non-depolarizing neuromuscular blockers, which are just pure antagonists on the receptor. So again, here we see the initial activation, then desensitization and paralysis. Again, this is a very, very common one. Usually the biggest or the most frequent combination you'll see during RSI is going to be etomidate and succinylcholine. There's a very, very frequent one being used. You notice here that it's a very, you give them 30 to 60 seconds after the sedation is pushed. So you want to give the sedation time to work, and then you can paralyze them. Pretty rapid onset, and then the duration is very short as well, about 5 to 10 minutes or so. Again, binding those nicotinic receptors, initial depolarization, and then finally you're going to have flaccid paralysis. So there are several contraindications that you should remember prior to giving succinylcholine. So this is why this drug is very deadly in the wrong hands. It's really important to remember this. And honestly, I tell you that probably 95% of the docs that I have seen who have come out of residency training or fellowship within the past, say, like 10, 15 years, they never ever use succinylcholine, right? A lot of your older providers, they will always use succinylcholine because that's what they grew up on, that's what they learned, that's what they use. A lot of the newer providers, they only use rocuronium, right? Because we'll look at the difference in contraindications and how there's almost none for rock versus with succinylcholine, right? But this is still a very effective drug, still get a lot of good use out of it. You just need to know who's going to be at risk for toxicity, okay? So the big things we worry about are risks of things like malignant hyperthermia. So again, we said that our inhaled anesthetics are probably the common ones you're going to see causing malignant hyperthermia, but this can also occur with succinylcholine, right? So inhaled anesthetics, succinylcholine are the two main drugs causing malignant hyperthermia. So you want to be careful of that. If they have any kind of history with it, if they have relatives, first-degree relatives that have this, those are things to be concerned about, right? Because you can initiate malignant hyperthermia in those patients. The other things you worry about are patients who have upregulated acetylcholine receptors on those neuromuscular end plates. Okay, basically what we're going to see is that when you have activation of all of these acetylcholine receptors, these nicotinic receptors are going to open up all those channels all at the same time, and potassium is going to be a big thing that flows out of those. Okay, so you're going to end up seeing when you give succinylcholine, you're going to have a pretty predictable rise in your serum potassium, usually about 0.5 to 1 milliequivalent per liter. Okay, so you can measure that, and it's going to happen in all patients. That's just the way the drug's working because it's activating all those muscle channels all at the same time. So patients who have upregulated acetylcholine receptors are more likely to see an even bigger rise in your potassium. And when you have big rises in potassium, what do you worry about? Arrhythmias, right? So you worry about having too much potassium can lead to arrhythmias. So you don't want to have that occur. So patients that have this are going to be those that have severe burns that are 2 to 3 days out after the injury, right? So some people mistakenly think that a patient who had just had a new burn, so say like you had your patient who's on their home oxygen and they were smoking over their gas stove, had that occur, they come in covered in burns, they can still receive succinylcholine 2 to 3 days after. You don't want to do that. If they've had a massive crush injury, again 2 to 3 days after, because it takes time for those acetylcholine receptors to start getting upregulated. Spinal cord injury can be another one, again 3 days out. Other things you want to be careful of is narrow angle glaucoma that can cause acute rises in intraocular pressure. You see that. If they have a acetylcholinesterase deficiency, so again that would lead to longer duration of action because they're not able to metabolize the drug as quickly. And then this neuromuscular disease, either a patient history of it or a family history of things like Duchenne's muscular dystrophy, ALS, things like that. You need to be careful because they're also going to have upregulated acetylcholine receptors. Okay, and if they have pre-existing hyperkalemia, also don't give it to them because, especially you think about renal patients who already probably have elevated potassium anyway. Don't want to give it to those patients. Adverse effects you can expect to see from succinylcholine, including those fasciculations. Again, those are expected. We know to look for those. The hyperkalemia, you see there, and then the bradycardia. Again, that will be, again, because you can have some of those activations of vagal receptors, muscarinic receptors on the heart. This is more seen with repeated doses of succinylcholine. So if, like, say, you give the first dose, not able to get the intubation, you have to give several doses afterwards. That's where you're more likely to see the bradycardia. And then to counteract that, what drug can we give? Atropine, right? We just talked about that one. So you can give atropine in order to help reverse that and bring the heart rate back up. Again, if you had a acetylcholinesterase deficiency, you can end up seeing prolonged neuromuscular blockade because you're not metabolizing the drug as well. And then obviously the malignant hyperthermia for those that have that ranitidine receptor change. Again, you may not know about that, so you need to look for a family history of it. You guys remember the drug to give to reverse malignant hyperthermia? Dantrolene is going to be the big drug there, right? Dantrolene, cooled fluids, and lots of sodium bicarb. Okay. So with those fasciculations from all those kind of muscles activating all at the same time, you can see some increases in intracranial pressure, sometimes in intraocular pressure as well, which is why we worry about the glaucoma. The ICP is the only really kind of clinically important thing that we're worried about, so that's why we can either give lidocaine beforehand, so that's why we want to give that as a pretreatment drug to prevent the jumps in ICP, or sometimes you can actually give a small dose of a non-depolarizing neuromuscular blocker beforehand, like rocuronium, to start to occupy those receptors and prevent as many fasciculations. Clinically, I'll tell you that if you have a worry about ICP, we just go ahead and just use non-depolarizing neuromuscular blockers. I'll probably just avoid succinylcholine at that point. Okay. All right, and then the hyperkalemia, obviously, you know, like I mentioned, pretty predictable rise in your serum potassium after activating all of those channels, kind of opening up a lot of potassium to flow out. But those patients who say have the receptor upregulation, like I mentioned, or if they have rhabdomyolysis, again, they're already lysing a lot of muscle cells anyway, releasing a lot of potassium, so you want to be careful in those patients there. Again, 2 to 3 days, probably 4 to 5, they're probably at most risk for that. That's why, so we mentioned burns, crush injuries, spinal cord injuries. 2 to 3 days afterwards is where they're most at risk for this, from having that. Okay, so just you're talking about this. Again, other things you may see, receptor upregulation if they're having myopathies, intra-abdominal infections, all these things. So just be careful with that. Again, if you have a renal dysfunction patient, if you don't know what the potassium is off the top of your head, I would probably just go ahead and use a non-depolarizing neuromuscular blocker for those patients. Then we mentioned the malignant hyperthermia. Again, obviously we're going to give dantrolene. how do you notice if a patient's developing malignant hyperthermia? Obviously, you're looking for the temperature, looking for new onset acidosis, rhabdo, DIC, all those things you're going to be looking for. So rare, but you want to be able to be prepared for that. So again, that's why I mentioned the malignant hyperthermia carts are usually kept in the ER, where you're most likely to use succinylcholine, and in the OR, where you're most likely to use those inhaled anesthetics. Okay. All right, so we kind of talked about that. So notice, we'll talk about reversal agents for some of the other drugs in just a few minutes here, but for succinylcholine, there is no reversal agent, really. It's all going to be just the tincture of time you need to give them time for the drug to metabolize on its own, right? So you can just support their airway, either back valve mask, whatever it happens to be, breathe for them until the patient's able to metabolize the drug and they start to kind of breathe on their own again, okay? And then the atropine can be used to reverse the bradycardia. That should be 0.5 milligrams to 1 milligram, not 0.05 or 0.5 point, whatever that is. Not right. Okay. So again, think about, if you already have a bradycardic adult, make sure to consider using atropine for them. And then if you're worried about ICP, pre-medicate with that lidocaine. Always need to be very careful anytime you're giving this drug. Make sure you get a good history beforehand. And make sure you're giving the sedative agents prior to giving your paralytic. Okay. So the next drugs are going to be your non-depolarizing neuromuscular blockers, going to be vecuronium and rocuronium. So obviously these are going to have a little bit different mechanism because they're non-depolarizing versus depolarizing. So here, instead of activating those nicotinic receptors, causing that fasciculation and then kind of wearing them out, here you're just going to have them sit on those nicotinic receptors and prevent acetylcholine from interacting with them. So it's a competitive antagonism of those receptors. Okay, it's going to lead to a flaccid paralysis. Again, no sedation effects, no amnesia, no analgesia, just paralysis. VEC I probably see more frequently being used for maintenance of kind of synchronization with the vent. So because it has a little bit longer duration of action than your rocuronium, you'll frequently see patients get transferred up to the ICU and then put on a VEC drip, where they will end up getting long infusions of that in order to help keep them synchronous with the ventilator. That way they're not fighting it due to that. So you guys think of any other reasons why you might want to paralyze a patient? You don't like them, maybe? So sometimes if you're worried about things like intraocular pressure, if you're worried about, intracranial pressure, if you need them to be completely still for any reason, if you're doing particular procedures where you need them to be still, these are all reasons why you might need short-term paralysis. Just keep in mind, you typically want to use these drugs for as short a period as possible. We'll talk about some problems with these a little bit later on, but just keep in mind, use as low a dose as possible for a shorter duration, because again, giving paralytics is something you only want to do when you have to, right? Because no one wants to be paralyzed unless they really need to be. But again, this is going to be good for kind of maintenance of paralysis. Usually for intubations, we'll use rocuronium as our kind of go-to drug. But the nice thing here is that they have very few contraindications. As long as you're not allergic to the drug, you're pretty much good to go. So notice how with malignant hyperthermia, you had just a laundry list of complications to worry about. This is why a lot of people, you just use rocuronium, you don't have to think about it, right? It's one less thing to consider when you're deciding what drugs to use. And notice here the duration is a lot longer, say 20 to 30 minutes. So for instance, when we were deciding what to use, kind of a peek behind the curtains a little bit. So like at the Nemours ER, when we were first deciding how we wanted our processes to go, we had a lot of newer docs who were very much in the camp of like, well, let's just use rocuronium. This is the better drug to use. There's no contraindications, fewer side effects. Let's just use that. But the chief of the ED, he was like, well, what if we need to do a neuro exam on these patients, right? Especially if it, time is of the essence. If you have a paralytic that only lasts 5-10 minutes, that wears off much more quickly than when it lasts 20-30 minutes. And so that was why the decision was made to go to using succinylcholine and Tomidate as the two drugs you mainly use for RSI for that particular institution. Other places you might see where they just use rock exclusively. So it really just depends on where you practice and what their habits are. Okay. Again, you may find that some patients will have prolonged recovery time with these paralytics. They have organ dysfunction, so things like, if they have liver failure, they may have these drugs stick around for twice as long as you may expect, so it would be a prolonged time till they're back to where they can lose that paralysis. So be careful with that. The other thing, we'll talk about some of these drugs that can cause changes to your hemodynamic status, but with vecuronium, rocuronium, really no effects on blood pressure, no effects on heart rate, so it's nice from that standpoint. Again, rocuronium is most common when ICUs for RSI, very similar properties. A less vagolytic properties than we're going to see with some of the other drugs we'll mention in a few minutes. It's a very good, easy to use drug, very few contraindications, very few side effects. So now you can reverse the non-depolarizing neuromuscular blockers. We said with succinylcholine there's no reversal agent for that, you just have to give it time. But for the non-depolarizing drugs, because it's a competitive antagonism at the nicotinic receptor, how could I reverse that? It's competitive with acetylcholine. Yeah, I need to give them more acetylcholine. So the way I can do that is by actually causing a temporary inhibition of acetylcholinesterase. So if I can block acetylcholinesterase temporarily, increase levels of acetylcholine, that's going to be able to kick off those drugs off the receptor and establish normal neuromuscular transmission again, right? So this is where we give a drug called neostigmine, or Bloxivers. This one I see used most often in the surgical setting in order to reverse these drugs a little bit more quickly. So you take your patient back for surgery, you paralyze them to get your whatever procedure done, and then you're bringing them back out. If you want to reverse that paralysis more quickly, you can give neostigmine to get them back to normal functioning again. So that is one reversal agent you can use for rocuronium, vecuronium, any of the non-depolarizing neuromuscular blockers. Again, very fast onset here. Here the duration can be a little bit variable, but I find that rocuronium probably lasts closer to the 20-minute mark more than anything. But it's again good for initially doing the paralysis, and then you can give repeat doses if you need to get the patient a little bit more compliant with you again. Okay. Again, keep in mind these NMBs are not going to stop seizure activity, so you do need to monitor for that. If you're going to have prolonged paralysis, you need to have a bedside EEG if you're worried about seizures. Okay, a few other neuromuscular blockers you might find out there in clinical use. These are probably going to be more seen in the ICU setting, not necessarily in the kind of the fast RSI type setting in the ED. But one we have pancuronium or Pavilon. Again, this is another non-depolarizing neuromuscular blocker, but it's very long acting, so it sticks around for a good long time. And this one is not good for cardiovascular patients because it actually is a vagolytic, meaning it's going to cause increases in heart rate, which can be problematic if your patient has issues with oxygen demand by the heart. So it can induce angina, it can induce potentially MI if you're at a very at-risk patient. So this one doesn't get used very frequently. Instead, it's been kind of supplanted by cisatracurium or Nimbex. Again, this one is nice because intermediate acting, a little bit shorter acting than pancuronium, but it's also really good for patients who have organ dysfunction. So if they have renal problems, if they have hepatic problems, this is a great drug because it actually gets metabolized through other enzymes, and so it's really good for the ICU patients who have multi-organ dysfunction. Okay, so some of the issues actually, I'm probably going to cut it here. Yeah, I'll finish up this section when we come back on Thursday. Do you guys have any questions or continue on? I keep you paralyzed in suspense until then, right? Okay, see you guys next time.